Hi, everybody. Good morning, good evening, good afternoon, wherever you are. Welcome to the IACH Traditional Journal Club. This is the journal club brought to you by the International Academy for Clinical Hematology. We are the 20th of July 2021, and this is our last journal club before the summer break. So as usual, I'd like to acknowledge Takeda Oncology for their support through a generous unrestricted educational grant. For the purpose of this journal club today, the scientific committee of the IACH selected this article, which is in press in the American Journal of Hematology by Dr. Richard and colleagues, and you can read the title, Selinexor, bortezomib, and dexamethasone versus bortezomib and dexamethasone in previously treated multiple myeloma, outcomes by cytogenetic risk. So, as you can guess from the title, this is a sort of a sub-analysis from a major randomized phase 3 trial, which was published actually a few months ago in The Lancet. So the purpose of this journal club is to analyze this specific topic that has been addressed in this article and not to go back to the original publication, because I know there have been a lot of correspondence, after the original publication in The Lancet about the choice of the control arm, about how, to understand the value of this combination. But I believe there was some nice discussion, and the authors have provided some good replies published in The Lancet. So I would refer you to this. So here, our focus is on this issue of cytogenetics and the value of selinexor, bortezomib, and dexamethasone. And I'm very pleased having with us the first author, Dr. Shambavi Richard, who is an assistant professor at the Icahn School of Medicine at Mount Sinai Tick Cancer Institute in New York. And she has really a very strong interest in the field of multiple myeloma treatment, but also the rapidly progressing field of CAR T cells and cellular therapies. So, Dr. Richard, thank you for joining us. And the tradition also in this journal club to have always another expert who did not participate or contribute to the work. And today we have Dr. Salomon, who is an associate professor at the University Hospital of Lille in the north of France. And Dr. Manier is really a top expert in the field of multiple myeloma treatment. So you can see here the abstract of this paper, and this is referring to the phase 3 so-called Boston trial, the one that I was just mentioning, published in the Lancet. And this is a randomized trial comparing selinexor once weekly plus bortezomib dexamethasone versus the classical historical standard of care with bortezomib dexamethasone. And in this analysis, in this work, the authors focused on the results of the high-risk cytogenetics, high-risk multiple myeloma patient. And what you can see from this figure published in the article, there is definitely an important benefit in favor of the triplet combination. Obviously, the p-value did not reach significance, but we will discuss this later on with our panelists. And when you look to the efficacy outcomes by cytogenetic risk status and treatment, this is also a table from the article. You could appreciate that the triplet combination with selinexor, bortezomib, dexamethasone led to a significantly in terms of an absolute value, I think a meaningful median PFS of 12.9 months. And of course, we will discuss this with our panelists, and we'll see how does this compare to the other available data using different regimens. So with this, I'd like to start the discussion with our panelists, and I'd like to remind all of you that you can send your questions using the chat box, using the Q&A Q&A icon, and I'll do my best to share them in a structured way with our panelists. So, Shambavi, Salomon, welcome. And also the tradition is always to say ladies first. Actually, I'll ask my first question to Salomon. And maybe Salomon, if you'd like to remind the audience, because this is quite a new field, what are the XPO inhibitors and what is the role of this family in cancer biology and its value in multiple myeloma specifically?
Yeah, thank you, Mohamad. Thank you for this invitation, and hello, everyone. So, Selinexor is a reversible and selective inhibitor of nuclear export, and of a specific nuclear export called exportin 1. So XPO1 is exportin 1. So the role of this XPO1 is it's often overexpressed in different cancer, including multiple myeloma. And it does induce the cytoplasmic localization of tumor suppressor gene. And so their functional inactivation, because they are not anymore in the nucleus. So when you block XPO1, actually you avoid this cytoplasmic localization of tumor suppressor genes. They remain in the nucleus, and so that they can induce the apoptosis of the cells. It also has a role with a translation initiation factor called EIF4E, which in the nucleus will bind to different messenger RNAs, including oncogenes, and will localize them to the cytoplasm for them to be translated into protein and act as an oncogene. And so by blocking this as well, you induce and favor the apoptosis of the cells. So this has been shown in different cancer, multiple myeloma, also in lung cancer, for example, or a variety of cancer where XPO1 is overexpressed. And it's a first-in-class Selinexor, so it's truly a new mechanism of action.
Thank you very much, Salomon. And indeed, this is really very exciting. And it is actually being tested in solid tumors, but also in acute leukemia, but also in lymphomas. And I believe in myeloma, until we have cured everybody, we still need to have all of these novel options. So this is really good news to have Selinexor now being available and approved. So Shambavi, now let's dig a little bit deeper into your work. Congratulations. And I believe I really liked the idea of analyzing the high-risk features in this trial, because we know that this is really a true unmet need. And also we have made a lot of improvement in multiple myeloma. The high-risk cytogenetics are still lagging behind a little bit. So how did you define the high-risk group in this paper, just to clarify to our audience?
So first, I wanted to thank you, Mohamad, and to the IACH for honoring me by picking my paper. I'm very happy to be here and to be able to discuss it. So as we all know, there's so much of a wide spectrum in how we define high-risk cytogenetics in myeloma, and there are as many different variations of this theme as there are papers on this topic. So we decided to pick, some of the more standard, the translocation 414, the translocation 1416, and the deletion 17p, which is actually the big three that appears to feature in a lot of the phase 3 randomized trials that later on had these kind of sub-analyses. And then, we threw into the mix the gain of 1Q, and we were debating a little bit whether we should use the 3 copies or the 4 copies, because again, there's a lot of debate on which, and we decided to go with a more conservative approach of the 4 copies plus, which just seems to increase the poor prognosis as compared to the 3. And then we analyzed this in a centralized, in the CD138 enriched cells by FISH. And we picked the cutoff as 10%. And really, again, there's so much variability in this, and we had to go with what would make the most sense with the kind of numbers that we had. And that's how we picked that kind of combination.
No, definitely. I believe the combination you have chosen is really state of the art and follow the latest advances in this field, especially this issue of amplification of 1q21. Salomon, what was your feeling about the definition used here?
Yeah, I think it's important to define them well, because if you want to compare both studies, I think the IMWG is valuable by the fact that maybe it doesn't depict absolutely all high-risk cytogenetic situation, but at least it's truly comparable. So I think I think it's valuable. They did well.
Okay, so Shambavi. Now let's move to the question about, since we're talking about high-risk cytogenetics, and I've been always told and heard that actually Protesm inhibitors are really the drugs of choice in high-risk cytogenetics. And here indeed, we have this combination of Selinexor plus bortezomib. So can you please remind us about the rationale underlying this? And I'll ask the same question actually to Salomon. I mean, whoever wants to jump in, both one of you.
So we had data from before about the utility of the PIs in both translocation 414 and the deletion 17p, right? So there's a little bit of a tussle, is it more effective in 414 or deletion 17p? So it's consistently effective, but certainly there seems to be some signals that they seem to be effective in these high-risk cytogenetic abnormalities. Then going back to the mechanism of action of these XPO1 inhibitors, the really unique thing about them is the way that they act on the tumor suppressor proteins, and P53 is of course one of the big tumor suppressor proteins that is present. And so it made logical sense that if we are looking at a mechanism that inhibits the cytoplasmic movement of these tumor suppressor proteins, and in fact force them to stay in the nucleus and force them to do what they're supposed to do in their wild type, right? So, and we did have some, preliminary intriguing information from the preclinical work and some of the STOMP data where there was a patient with the deletion 17p that just seemed to live a lot longer than we would have expected in this situation. So armed with all of this, we were really interested in this, and that's why it was it was a pre-specified analysis. We were interested in looking at what it would do in this situation with the deletion 17p, and of course with some of these others. Then added to that is again the preclinical work where there was synergy between the Selinexor and the proteasome inhibitors, and in terms of their mechanism with the suppression of the NF-kappa B pathway and all of those. So then, so it just seemed to be a pretty logical, next step in this whole process to focus on that as one of the more interesting or more important things that we focused on in our sub-analysis, the high-risk cytogenetics.
No, that's very nice. And I think, Shambavi, you're alluding to the work that was done by Dr. Baylis and colleagues, published a few years ago, with in vitro, but also in vivo data. Maybe Salomon, a comment on this?
No, sure, and I agree with everything Shambavi said about this potential synergy also can say that we can see synergy a little bit, everywhere. And it's always difficult to distinguish between true addition and synergy. But there is one thing, as you mentioned, which is interesting in the combination between Velcade and Selinexor. It's about the NF-kappa B pathway, as we said. XPO1 will induce the cytoplasmic localization of some of the tumor suppressor gene, including I-kappa-B, the inhibitor of the NF-kappa-B pathway. And so it blocks, by blocking XPO1, it blocks its cytoplasmic localization. It stays in the nucleus, it induces its tumor suppressor actions. But so that's the action of Selinexor. But we know that bortezomib also, by blocking the proteasome inhibition, will also induce degradation of NF-kappa-B pathway. So that's also something interesting by accumulating two mechanisms of action on the same pathway and potentially increasing the action through this NF-kappa-B pathway. So that has been nicely shown by Nizar Balis and his team, and as well in lung cancer in a nice Nature paper published in 2018 as well.
Excellent. So on paper, everything's look wonderful. We have the proteasome inhibitors. They are good partners for XPO inhibitors. So we have Selinexor, and they are joining forces, and we have the biological rationale for this. So let's now dig deeper into how do these results, the one, because I mean, when you look to the numbers, 13 months, that's fair and rather good, I think, in this high-risk population. How do these results compare to the other Vel-Dex combinations we know? Because I think we have daratumumab, bortezomib, dexamethasone, which is approved based on the CASTOR trial. We have pomalidomide, bortezomib, dexamethasone, which is approved based on the Optimism trial. So if you take this VD as a backbone and look into the partners, Shambavi, how did you feel about this?
Yeah, it seemed like the logical thing to compare it with the, of course, we all know that cross-trial comparisons are fraught with all kinds of issues because the design is not completely the same and there's all kinds of differences. But the CASTOR and the Optimism are two good examples of a triplet with the VD backbone and with the control arm being the bortezomib and dexamethasone arm. So they started off, I think, well, first of all, I think with the CASTOR trial, for instance, the for both of the arms, the experimental as well as the control arms, the VD was stopped after 8 cycles and then proceeded, which was a little bit different from the Boston trial. Secondly, in the Boston trial, crossover was allowed. So from the VD arm, if patients were progressing and if they were still able to tolerate the bortezomib, they were able to cross over to the XVD arm. So there are differences in the design of all of these things. When looking at the subset analysis for the high-risk cytogenetics, again, interestingly, in the CASTOR trial, this was done in the local, sites of the trial. So basically, there was not a standardization. Some of them were done by karyotype, some were by FISH, some was a combination of the karyotype and the FISH. There was no actual standard as to the, how you define these cutoffs and what are the criteria used. And so there was so many variations that really make it difficult in the end to know if you're actually analyzing what you are starting off thinking that we are analyzing. So then in addition to that, then we have they basically, in the CASTOR trial, they basically looked at the 414, the 1416, and the deletion 17p. So 1q was not a part of that high-risk combination. that high-risk mix. The deletion 17p had a much more stringent cutoff than our analysis did. They had a 50% cutoff for deletion 17p, which is, less controversial. Almost everyone will agree that at 50% you are truly high risk. I think there's a lot of controversy over, is 10% the same? And not to mention, we're not even going to hit on the biallelic and the monoallelic because they were not relevant to either of these trials, but there's a lot of questions about how we define deletion 17p as a high risk category. So, so we have a lot of these different things. Then there is the whole question of how much of this high-risk fish was able to be retrieved from the trial. With the castor, I think they had about a 30% or so missing cytogenetics, and ours was not as many. So, and again, ours was central, so that was a little bit different, and it was a little bit easier to standardize.
But I need to be fair. You had 10% missing cytogenetics.
We did have a 10% missing cytogenetics for various reasons. Most of it was just for analysis technical issues and things, but nevertheless, 10% was not, we were not able to.
I do agree.
So, so then the high-risk population in the castor trial was about 75 patients. I think there were about 40 in the experimental arm, about 35 in the control arm. So they had a total of about 75 patients. So, and then, so finally, in terms of the differences in the median PFS, there was an update at about 40 months, I believe. And so in that, they basically, there was, in the experimental arm, the median PFS was about 12.6 months or so. And in the control arm was about 6.2 months. And when you compare it to the standard, it was about 16.6 and 6.6. So, so all of this, so these were the results from the castor trial. Again, very hard to do these cross-trial comparisons, but I think what seems to be, in general, what we see with all of these, whether it's castor or optimism and all of these, is that the triplet does seem to improve the median PFS for the high risk as compared to the standard risk, as compared to the control arm. However, they don't seem to abrogate the risk completely, or in other words, they're not approaching the same kind of median PFS as a triplet in the standard risk arm. And that seems to be the general story across the board. And I think the holy grail is to try to get to that place where you're truly overcoming the effects of the high risk. And that'll be interesting to see. I think well-designed trials are really going to be important. Standardizing is going to be important, and trying to, and then to really analyze and see where we are. I think that's where all of this stands. So speaking about the Optimism trial, I think we have somewhat similar kinds of things. We do, that was a PVD versus VD. And again, here it was even more complicated because, again, looked at the same three, the 414, the 1416, and the deletion 17p, but there were no cutoffs here at all. So basically it was anyone who had any of these abnormalities at any kind of level was considered high risk. So right off the bat, we're really talking completely different entities in this case. And so basically then with the median PFS for the high risk was somewhere in the range of 8.5 months or so for the high risk versus about 5 and change for the control arm. And it wasn't that different for the standard risk. It was about 11 months and 7 months. So it was not that different. And that was at about a 30-month update. So.
Excellent. Salomon, do you share the same enthusiasm?
Yeah, maybe for the optimism, we can also say that most of the patients were LEN refractory, so the population is not exactly similar, but absolutely. And maybe to add another, kind of general comments is the fact that we'll face more and more relapses, first relapse with DARA and lenalidomide refractory patients. And we need options without DARA-based or anti-CD38-based regimens for relapse. So I don't say that SVD will become a standard of care, but it's potentially one of the options for drugs that will be able to be applied to these patients for first relapse. So that's something also that we need to consider for the future, and this will come probably very early.
Excellent. So here we have a few questions from the audience. So I'll try to group them. Shambavi, do you have experience about the efficacy of Selinexor after CAR T cells or bispecific antibodies? So my guess that we're talking about highly advanced patients.
Yes, very interestingly, we participated in the STORM trial, and we actually had a couple of patients, as obviously just a couple of patients who had relapsed post-CAR T. And both of them actually did have a several-month, response with Selinexor post-CAR T. So I think that's another area that would really be interesting to see, if in some way there's, if we can study this in a more systematic way and see if there's truly a space there for Selinexor post-CAR T.
Yeah, I think this is becoming crucial because Salomon mentioned that we will have more and more patients receiving daratumumab frontline. They are lenalidomide refractory. CAR T cells, we have ide-cel approved, but probably they will move rapidly into earlier stages. So rapidly we will need some options. So good to hear that the Selinexor worked after CAR T cell. Any thoughts on this, Salomon?
So we didn't have this experience of CAR T then after Selinexor. It didn't happen in the department. We also participated to the STORM trial as well. And just one thing, a little bit independent of that, but we have observed some of these very long responders, kind of exceptional responders. And some of the patients didn't have a good benefit of the drug, but a few of them had this very prolonged response. And so that's also something interesting, and we want to understand in terms of molecular biology, who are those patients? Why do they have this long-term response? Some preclinical work was also interesting in regards to the KRAS mutations, and potentially patients with KRAS mutations would be more dependent on NF-kappa B, and then the Selinexor would have a specific effect on that. We don't have, this was on lung cancer, we don't have this data on multiple myeloma, so that will be also interesting to be able to identify those patients, even late stage, that could truly benefit from the drug.
Excellent, thank you very much. So Shambavi, we have a few questions about the safety, where I think here clearly in this triplet combination, the tolerance was rather good compared to the original schedule when Selinexor was used as a single therapy. Can you maybe comment on this and provide some guidance to the audience?
Yeah, so the incidence of AEs and SAEs were definitely very high in the triplet arm. Over 90%, 95% had some form of an adverse event or the other. The most common was
but not severe. Not severe, I guess.
Yes, exactly. Most of them were manageable. The majority were grade 1 or 2. We did have, of course, some grade 3, 4 when it came to thrombocytopenias, but not clinically significant. So more grade 3s. Clinically significant bleeding was not nearly as common. So for the grade 3 for thrombocytopenias, for the high risk, it's about 50% or so, as compared to maybe about 30% in the control arm. So that was a big one. For the non-heme toxicities, the pneumonias were pretty similar across the board. It was about 11% each, so not particularly more, but nausea and GI side effects was also something that was much more in the Selinexor arm. On the other hand, the peripheral neuropathy was much better in the Selinexor arm, again, for obvious reasons, because the Velcade was weekly in the triplet arm versus the standard 14811 in the control arm. And particularly, we also analyzed these safety profiles for high risk versus the standard risk. And we found that, again, for grade 2 or higher peripheral neuropathy, for the XVD was, for the high risk arm was 25% versus about 35% for the standard risk groups. So all across the board, yes, there are more adverse events for the triplet arm, but that is probably holds true for no matter which triplet arm that we look at. One thing that we used a lot of Selinexor because we were part of all of these trials, both Boston and Storm, and so we found that if we were proactive and jumped onto prophylaxis early and right from the beginning, a lot of these could be very well managed with just aggressive supportive care. And so for the nausea and emesis, we always started with this triplet regimen of of ondansetron plus rolapitant, and then along with that some olanzapine, and this combination right from the beginning with followed for the first 3 days, 2 or 3 days post Selinexor with just round the clock 5-HT3 antagonists and things really did help to mitigate all of those. Also, we brought them in pretty frequently initially to make sure that they're getting properly IV hydrated, that their sodium levels were monitored, that their weights were being monitored. We had the nutritionists on board to have them, because of the asthenia and weight loss, and all of these are pretty significant if you get behind the 8 ball. So we just wanted to get in ahead of this. And with all of that, really, these side effects are reversible, and they're not long lasting, and generally happens in the first cycle or 2, and then everything kind of settles down.
Salomon, do you have the same feeling from
yeah,
your
absolutely.
practice?
I agree absolutely. So the general impression is that the weekly Selinexor is the tolerance is much better than the bi-weekly as in Storm Selinexor dose. So the tolerance in Boston was much better, and we didn't face the same side effect and GI side effects, especially that were problematic in the Storm trial. So I think the weekly dose is now a good dose to use Selinexor, and so that the patients will tolerate them well.
So we have a question here from Dr. Arshibong Hogan. Hopefully I'm pronouncing it well. Do you believe that dose escalation of Selinexor plus VD could have improved the results in the high-risk multiple myeloma? Shambhavi?
So we used the doses was about 100 milligrams weekly of the Selinexor with the Velcade and the Dex. They are actually very tolerable doses in that combination. So, of course, if we are combining Selinexor with the IMiDs, we have to reduce the dose to about 60 milligrams, which seems to be the best tolerated dose with most of the IMiDs. So, I don't consider it particularly dose escalation. I feel that that's the appropriate dose to in that combination. But of course, if patients are not tolerating, we dropped it, it's still extremely effective because of its synergy. And so we drop it to 80 milligrams or, even 60 milligrams occasionally, but, and it's still, we still found efficacy in all of those doses.
Excellent. We have a question from another colleague who didn't put his name, which is about the BRAF mutation and Selinexor. And I guess the colleague is alluding to some old data showing that at time of relapse, some myeloma patient will have a BRAF mutation. And I remember that we have tested verumafinib in several patients because this is the targeted drug used in oncology. Any thoughts on this, or did you hear about something, Salomon, in this area?
No, I'm not aware of data specifically on BRAF mutation, and we know that BRAF mutation is probably less than 5% of the case. So I guess we don't have much experience. Indeed, it has been associated in some cases with EMD and relapse on extramedullary disease. But so there is this work on the KRAS mutation and the dependence on NF-kappa B. Is it the same for all MAP kinase mutations, including NRAS and BRAF? Question mark here. I think we don't have enough data on that, but that's interesting. Potentially melanoma that can be studied as well.
Okay. Work in progress. So this is really very exciting. Let's take one last question from Dr. Andreas Reinisch, which is about the experience of Selinexor after belantamab. I'm aware, and we have some cases, and it works well, but maybe Shambavi, you have a comment on this?
Not specifically. We do use a lot of belantamab, and we use Selinexor before or after, depending. At some point, I think one of the big questions in myeloma is how do we appropriately sequence all of these huge armament of drugs we have? I don't think we have specifically identified that there's a specific sequence between Selinexor and belantamab. So we use it, ad hoc at whatever seems appropriate at the right time with the patient. I think the issue again is with the post-BCMA and how is all of this. So it's a similar thing with CAR T and the BiTEs, because most of them are targeted to the BCMA. And how is this going to play out in the future as we get a little bit more experience? And is there a way to sequence this better? This is, I think, under the umbrella of the big sequencing question.
Well, fantastic. I love this optimistic conclusion, Shambavi. Obviously, unfortunately, we will continue to need all of these drugs, and it's going to be challenging. And probably, although we don't talk frequently about it, this is about personalized treatment, knowing your patient, clinical judgment, how we're going to sequence drug A, B, C, BCA, DAB, etc. But I think the good news is that we have more and more combinations. Congratulations for this really very nice work, and it's always good to comment on the results in this specific hard to treat subgroup of high-risk cytogenetics. But also I was always very pleased recently to see that now the community, the myeloma community, is developing specific trials in the high-risk cytogenetics. We heard at last ASCO and EHA about the concept trial from Germany. We heard about the Optimum trial from the UK, and many other trials will come. So here, I think the advent of Selinexor is really bringing added value. Thank you very much. Thanks to all our audience. Wherever you are, you need to stay safe, because it looks like that this Delta variant of COVID is behaving quite nastily. So please, guys, be careful, stay safe. If you're enjoying some summer break, I hope you will have some rest. For us at the IACH, the Journal Club, we'll take a break now until end of August. We'll start again, so you have to stay tuned. But the IACH activities will continue. Next week, we do have a very nice webinar about post-EHA and post-ASCO data regarding multiple myeloma. This week, I think in a couple of days, you will see it. We have another webinar on CAR T cells in lymphoma. So thank you all for being very loyal to the IACH activities. Thanks, Salomon. Thanks, Shambavi. You did really great. And wherever you are, please stay safe and keep well. Goodbye.
Thank you. Thank you. Bye.